Welcome to Health Stealth Radio, where we move away from the mundane to gather insights from the shadows of enterprise and patient cybersecurity. Yes, we surely believe that traditional themes like endpoint software and zero trust are critical, but given massive advances in AI, remote and wearable device hacking, and data hostage negotiators, there's a much darker side to cybersecurity, and not everyone is quite willing to talk about it in public. Health Stealth Radio will thrive on these topics and encourage fireside spats to debate them. Here's your host, Frank Cutitta.
Just like to welcome you all to Health Stealth Radio. I've got the honor, and I'm a huge fan of Mike Mosquito. Could you just introduce yourself and tell us what your major work is, a day in the life of?
Well, it's been a whole lot of work this summer, Frank, but to let you know who I am, again, an industry, I would say, long timer here. Started at McKesson and moved my way through the ranks of several other companies. I've been a consultant as well, an advisor for in the consulting industry. And I left for a period of time to go learn some tips and tricks from other industries so I can bring them back into healthcare. So that's why I have this varied approach. I'm a mechanical engineer and materials miner by trade. And so my thing is putting things together that are broken. That now I'm working with Northeast Georgia Health System, Innovation and Emerging Technology with CIO, helping him see around the curve of what's coming in the landscape. They've got the new Da Vinci robot up there. So while being a rural hospital, they're a very bleeding edge on some of their technologies that they're adopting and taking on board. My cool ideas are usually ideas like the first digital assistant or nursing tablet that was developed at McKesson. And so when you see me speaking at a conference, it's curating current information to be able to talk to the audience and educate them on it, similar to what you've heard me do on some of the other podcasts and radio shows. Someone sitting in the audience that may either be building something or a hospital or health system that may be looking at acquiring some new technology and bringing it online. So I enjoy that mix of being able to talk and investigate, discover, and innovate.
Working with Chime as I am right now, I've worked with HIMSS in the past. I mean, we do a lot of conferences, we do a lot of research, and I say that a lot of this is affirmative, that we sit there and listen and say, yeah, makes sense. Everybody's saying that. So what we're trying to dig out here, could you talk a little bit about some things that you see popping up? You mentioned Da Vinci. What are some of the things that you're saying that are not really affirmative, but really future thinking that are actually starting to happen right now?
Well, I will say that AI interaction, relieving that time of the physician through automation of being able to ambient listen in the room and face the patient. So that's already happening. We've got hospitals that have already moved AI into listening, documenting, and making sure that you capture that physician and patient interaction live. It's moving now into that realm where we're talking about how does the patient take this information home? How do you use AI to interact with the patient more? So while we have AI doing this listening, what we're not doing, and where I'm involved very heavily, is on how are we talking to patients in their language. So imagine, Frank, you went to the Olympics, you need to go to the hospital. Do you speak fluent French? Do you speak enough French to get yourself through the hospital? So imagine anyone that comes to the US that needs to go to the doctor and may need to follow up. How do we talk to them in their language? Well, AI is doing that now. I have a product that we're working with that product now can interact with the patient. Is being used in mental health interaction right now to help treat patients on the fly on their mobile device. We can interact with the patient in their language. Post-discharge, your information comes to you in your language of choice. And it doesn't matter, most dialects, we've been able to find that interaction is enhanced by that patient feeling more comfortable in communicating in their native language. We know that AI is going to help with radiology. So you go get a radiology scan today, we're looking for a targeted area. AI is scanning the entire body in that area to find what other anomalies in your body may be popping up and being able to retreat and catch things that you may not have been able to treat in the past or may not be able to see in a timely fashion.
I didn't even have to tease you into the cross-cultural question. I'm a graduate professor of cross-cultural communications in healthcare. So talking about languages is absolutely critical, and the unstructured data that we can get from that. The other thing that's interesting, I like your thoughts on this, is that we get the language right. close to it.
Close to.
Sometimes it's more art than science, and that's where it gets dangerous. Like getting Google Translate to do your marketing brochures.
Right.
Sometimes it gets a little scary. But the other part of it is the emotional part of it, as opposed to just the language. So, the cross-cultural aspects of pain.
Exactly. And you got to think, as the world gets closer to understanding healthcare in that native language, with those disparities, with those cultural differences that are migrating to and from, we've got to be able to communicate and change that patient engagement model, Frank. And I think that these tools, they really relieve the pain of communication, because when you don't speak a language, think people that come to the United States, they give you discharge summary, they give you instructions. If you don't speak English or have someone close to you, and I can tell you this happened with the CEO of the company that we're working on this technology with. Karen walked out of a hospital here in my state of Georgia. She speaks fluent English, Spanish. That's what was her chosen language for all communication. And there was zero communication given in Spanish. Yes, of all language, you would have thought that would have been easy, right? Never even a piece of Spanish sent to her. Spanish should be easy for us today, and it's not. So a lot of technologies are claiming that they can do this. You've got to watch how you train these new technologies as well on communicating with the patient in a healthcare setting.
Especially as it deals with behavioral issues and mental health issues. I mean, you talk about changing the patient setting and the way we approach the patient. One of the things I'm looking at in technology, and maybe your experience could talk about that, is how we get patient satisfaction, how we gather that. Are you seeing anything in technology, or do you have any vision of how we could do more instance-based patient satisfaction? Or I call out that in one of the articles I wrote, the Uberification of patient experience, where we get in the car with the Uber driver and they said, how's Charlie doing?
Right. How's he doing it on the fly?
Exactly. And we're right there. We're in the back seat and we're not even a mile away from my house.
Right. Exactly.
How do we do that in healthcare?
I will tell you that. I mean, again, the mobile app, the platform for mobile is going to become more prevalent as you see these technologies move faster. This younger generation is going to allow for that to happen. That instant Yelp of healthcare, I would call it, right?
Like that.
That's going to happen. It's the Yelp of healthcare that allows you to engage. Bot on Health app that I was talking about there that allows you to communicate is doing that in mental health. It will be able to, on the fly, talk about, I've got an interaction here. And I will tell you how healthcare is bridging other industries. I spoke with commissioners of gambling last month, and in learning how gambling addiction and that mental triage that's required to help someone move beyond that, you've got to be able to interact in the moment. Someone's just spent a large amount of money and they're getting ready to double down again. By regulation, there's a pause, a timeout period required to make sure that person's getting ready to do no harm.
In the casino.
It's actually on the mobile app.
So on the mobile. Oh, on the app. Okay.
On the mobile app, that's the biggest contributor to gambling now, because you can in your car you can gamble
anytime, any place,
right? And so these mobile apps have taken hold, and these gaming commissioners are trying to figure out, how do I limit the demise of our casinos through these mobile apps, because these folks they're addicted to these mobile apps day and night. And so we're putting in these protocols where on the fly you can interject a pause and direct that potential need to some help and assistance in that moment on the fly. So in us working with building this application in the gambling and addiction industry, it is, how do you get that immediate feedback on the fly? It should be the Uber Yelp of today in healthcare, or did my doctor do well in this care setting today? Forget the entire, like you said, 100 days. Was today good?
Sure.
Is tomorrow the same? Did my quality of care go up? Is it trending flat? Or is it really trending down? You got to get me out of here.
Mm-hmm.
And you should know that as a health system. You should be able to say, yes, we're doing well by our patients, be able to trend that information and change based on that information.
So you're saying there's sort of like a frenzy meter on there. The person is in a gambling frenzy, and it picks that up and says, whoa, slow down, dude.
100%. That's one of the coolest. And us developing this app, I will tell you, Frank, I learned a lot about how healthcare is affecting other industries and how it should be affecting other industries, to make sure as people engage in, whether it's play or work, how do you protect them from themselves? And then how do you provide care on the fly? I've got friends that are running companies here in the state of Georgia and all over the place that are understanding they've got to be able to build a better mousetrap for getting to young people and people of age that are going through these mental struggles. So when we talk about these new tools, it is also predictive in its nature of understanding humans and how they work in and around things that may harm them. And I think that changes the care setting as well.
I think the interesting thing is that we never would say this even 3 years ago, but we have to be careful because the algorithms start acting out. It makes me curious about the developers of the algorithms, that these, they might be data scientists, they're obviously programmers, but how do you build those softer skill sets of algorithmic psychiatry into these apps?
You've got a code builder right there on the fly. What does that look like in the future? Because you've got to make sure hallucinations are not drifting in. You've got to make sure there's checks and balances. And in speaking with the CEO of CHCIO last month at a conference, I was at the Health Impact Conference, and we had on stage, he addressed hallucinations and its potential impact in healthcare, and how you have to be able to make sure these algorithms have a check and balance on a regular basis to make sure what they're being trained on, how they're being trained, maintains the same level of understanding and duty to do no harm, just as a physician. You've got to enable these tools to be able to work in that same manner, which means the writer, the developer, the designers of these tools and these new assets of AI have to make sure that these algorithms are maintained at the same level of care as a physician.
There's a liability lawyer waiting at the other end as well.
And that's what everybody's waiting on that. They're waiting on the first, you did it. I ran a lunch and learn earlier this year, and I had hospital exec on one side, had an AI company on the other side, and I had a CIO ask a question of, so if the tool goes awry on a patient, who's at fault with the data being wrong? The hospital exec said, well, I bought your app and I expected it to work as designed in how you sold it to me. The designer came back before the sentence was complete and said, but I'm using your data. And so you've got this data out there. When you start modeling off this unstructured data, I think you're going to find that now the words that weren't spoken in the room can be spoken in the room because we've got more to talk about.
So what are you hearing out there about hospital at home? I have an interview later today with David Levine, who's like the godfather of hospital at home pilot programs. He's doing one on skilled nursing facilities at home now, migrating that to the home. Do you hear anything about that out there?
Virtual nursing is providing for that in the hospital and in the home setting. And I think that is one of the first pillars of hospital in the home. You got to have someone that can actually interact with a patient, not in the hospital, but in the comforts of their four walls. It's going to become a concierge medicine will be at the next level with this before too long, where you drive to us or you want the package where you stay there and we bring the hospital to you and we're able to provide this list of services. You pick and choose, and then we'll deliver that to you in a box.
So I think it's an interesting phenomena, and I think Levine with this skilled nursing facilities at home is really, it's going to be interesting. I think you'd like that episode. So like I said, every conference I go to, everybody has some color of high acuity care at home that they're bringing out. So I think it's a thing to watch. We can't go through a discussion like this without talking about cybersecurity.
Cyber is paramount. I'm speaking about protecting patient data in a cyber world, a cyber conference, and we're talking about cyber and the protection of all this vast amount of data that's being collected. What's required? What's the fiduciary duty of the people that are gathering this information, using this information, and the patients that now they should own their information? This is the patient's data. It's their information, but the hospital holds it. And so what happens when you've developed a strategy, but not the governance of the data? You develop a strategy to use it, but not the governance around how to protect it. So what does that look like for us as we gather more and more and more? And when a patient wants to become part of let's just say a clinical trial, that data gets distributed in how many different areas?
You and I have been around this for quite a while, but I have to say that your eyes used to glaze over when you heard the word governance. What I find right now is that governance is really cool.
You're 100% correct. I just left Chime's Leadership Academy out in Utah, where we covered governance and on a very serious topic. And we had one of our CIOs showcase the governance model for bringing in innovation and technology and looking at the underlying systems that support it. And so you have to put these governance structures in place. I urge anyone when they ask me about, hey, Mike, what's the AI tools that I need to bring on? I'm like, what's your governance model to accept, adopt, understand, and support these AI tools? Because if you don't have a governance model for the inception of AI, you're doing a disjustice to your institution. You've got to understand that you've got to bring in your clinical leadership to help you understand how it'll be used. You've got to be able to bring in your operational IT leadership to understand how we're going to ingest and support these tools. You've got to have a model that also helps you understand, are we ready for these types of tools?
Yeah, and let me know when it's being used. You're an award-winning innovator. So are you seeing innovation in governance?
Oh, so yeah, I throw a bomb in rooms when we start talking about this. I asked a question, a room full of executives. It's a cyber conversation. I said, well, did you pay the ransom? And I throw that out there just to poke the bear a little bit, just to see what people will say. You get 50-50. Some say, yes, you have to, but you still have to do the same work. You have to go through the same scrubbing of your infrastructure to understand what was left behind. Are there other bombs left behind that are going to affect you later? As far as the governance and what's new and innovative, I am seeing some new models of innovation around how to take on governance because this envelope of AI is being pushed in front of so many folks. And so it's how do you explain what is innovative and what governance needs to be put around these types of tools that are going to be used in the clinical setting. So the governance model is about ingesting these technologies the right way, understanding them, protecting them, and then protecting them for patient use. So I've seen these models crawl, walk, run, and I've seen them get straight into running.
Are there certain areas in your work, both on the sell side and the buy side, that you see really are getting scary in terms of shortages?
I think that we keep hearing there's a nursing shortage. I think there's a nursing understanding that's required out there. I think we need to move people back into understanding that nurses are needed. I think the upskill, which is one of my passions, I'm starting something called an upskill program where you don't need to, there's certain people that won't go to college that are very smart around these new technologies coming out, Frank. I think the trade schools will change and morph into becoming innovation schools where you're going to get these sets of skills that are going to be required to manage this new infrastructure of AI, algorithm management, protocols of understanding how they're going to be used in these care settings. And you don't need a college degree to do that. And I've had this conversation with several folks out there about where are you going to get this new farm of people to put in these care settings, whether it's in the home or in the ambulatory setting. Where are you going to get these folks? Where are they going to come from? Because we have a large population of healthcare that's going to be retiring before too long. We know that's coming. And so I think that we have to start training this new generation of young people now on these tools and giving them the skills to understand, one, how they'll be used and where they'll be used, and then how do they use these tools to keep innovating and keep these care settings moving forward. We know that treatment in the home is coming. You're right. This new podcast, this other podcast you have coming up is spot on. It's going to be moved to the home because that's what this younger generation, they don't want to have to go to a doctor's office. They want to get it. They want to order their food on their phone. They want their groceries delivered from their home phone and delivered to them, and they want their doctors coming to them.
Well, from a caretaker's point of view, the clinician point of view, everyone I talk to about this new home care model, the hospital home model, and when I see it in effect, it says that this is the very first time I got to see the proverbial social determinants of health. Because they come into the hospital and they say, "Do you have cornflakes? Do you have beef jerky?" "Oh, no, I don't eat that stuff." They go into the home, they open up the cabinets, cornflakes, beef jerky, Cheez-Its. And so they love it because you're not getting the full story in the ward. Right. So it's really interesting. So yeah, no, I totally agree with you. So my producer will strangle me if I go long again one more time. So I want to ask one more question. You've been on the buy side and you've been on the sell side, and you're a student and a professor at Chime and at HIMSS of all these things that we're talking about. What would you say are some of the buzzwords that are like scratching your fingernails on the chalkboard when healthcare professionals hear them. I'll give one. I just wrote an article about AI washing. So it's you can't have a brochure, you can't have a TV ad without having some kind of mention of it. Then you scratch the surface and say, well, exactly what is it? But well, I'm not quite sure there's much there. What are some of the other things? It used to be pop health that said, I know what both of the words mean, but I don't know what it is. What are you seeing are the confusing things in terms of partners that sell to people like you or that you sell to other people?
Well, there's still the buzzword of blockchain out there. What does that mean? And we know it had an early rise
Hmm.
and a very quick death.
Hmm.
And we haven't heard much about it since. The overuse of AI. Everyone that has an app or a service out there has AI now.
Hmm.
You can't get past it. So the overuse of that word is, you're right, it's out there. But I think that blockchain out there, I think we keep talking about cyber. Everybody talks about having a cyber program for you, but everyone has already been down this path. It's what are you protecting against that you can or can't see?
Yeah,
And that cyber, the word cyber needs to be defined based on your use case, your health system, your
exactly.
tools that you're using. And I think that's what we throw it all into a bucket, Frank. And I think that we don't understand what the underlying meaning of cyber really is for us today.
Hmm.
I go to a conference and I hear someone speaking. I'm like, you're giving the same thing. If you ask Alexa, you'd be saying the same thing the other 10 guys said. Boil it down to specifics and where it's going to be used. When I talk about protecting strategy, practical strategies for protecting patient data and the cyber around it, I am talking about the layers required for the consumption of data, where it's hosted and sitting, and how you keep the bad guys from getting to it, no matter where it's transported. And that's important to me because I have kids and I have technologies that touch my world that I don't want someone to, oops, I'm sorry, we let that out. Someone else
Right.
is, right? And so I think that cyber word needs more definition around where it's being used, how it's protecting, whether it's IT or patient. We need to make sure we understand what cyber is. But I think you're right. The AI buzzword, when you look at this board behind me, innovation is a lot of things to different folks.
Oh
Some
yeah,
move
yeah, yeah.
slow, some move fast.
No, it was. I mean, there's zero trust washing too. I mean, everybody has zero trust, and so you can't have a product without having it. Yeah, I think your point about cyber. Cyber is not. It's like interoperability. The famous quote is that interoperability is not a technology issue.
Right. It's
Uh,
100%. How long have we heard that word interoperability? What is
yeah,
that?
yeah. So, but it's a human issue. It's not. People don't want to share. So interoperability means that if it doesn't work, it means that it's the technology is surely there, but people don't want to share.
I will tell
Same
you
same
one
thing
more,
with
Frank,
cyber.
on that.
Go
I
ahead.
will tell you digital transformation. Everyone talks about digital transformation. It's one of the words I've used. It's one of the words I still use, but digital is everywhere now.
Mhm.
So if you haven't transformed already, you're really not in business anymore. So when we talk about digital transformation, we're not talking about someone moving from fax to your computer. This is about how do we move the current landscape of people into a new age of use. So digital transformation is already here. Every transformation that you see over time, whether it's from paper to EMR, that transformation is occurring in front of us. So what does it mean for the next iteration of digital? It's happening in our home. It's happening in new settings of care. That's what digital transformation is today. But that whole digital is now, it's table stakes.
I do an exercise where I have people define digital transformation without using either word in it. So it becomes very, very difficult and they have to give an example. Okay, well, we changed a piece of paper into a PDF file. Okay, so we're talking about it's pablum. So we're not really talking about digital transformation. So I write about post digital transformation, which gets people really scared because they
Right.
said, wait, I think I missed digital transformation, and now there's a post digital
Right.
transformation. So what am I going to do? But going back to cybersecurity, I think the same thing as innovation, that it's not a technology issue. Cybersecurity, obviously, everybody said it because it's the human factor that gets the breaches. And now it's not even that. It's the solutions are not technology. That I had a data hostage negotiator interviewed a couple months ago. So, I mean, how do we finally hold our nose and say, okay, we've got to negotiate with these people, and who the hell do I get to do it?
Right.
So I mean, this whole field of Chubb and other people and professors that do this in cybersecurity classes, going in and trying to get your data back. So,
Right.
so anything else that I'm missing here, Mike, that really you just I can't believe he hasn't brought this up. And here's what I'm hearing all the time.
I think, for me, it's looking at these conferences I've attended this year, Frank. I've seen a new landscape of interest in understanding the radiology tools that are out there and the care. My brother is a recipient of AI finding a treatment
Wow.
for him, and it was a blessing for our family.
Mhm.
So I can't say enough about the doctors and nurses that helped him. But I can see where these tools are saving lives. And as I go into these conferences, from Vive to CXO summits, companies like Disruptive Innovators that are putting folks in a room and having these hard conversations to educate and understand what's happening in this landscape today. I think that's important to talk about these buzzwords and how they should be used. I think that's the important. What you're doing here is educating folks on Health Stealth Radio. I think that's still required because we have people developing technologies, but they don't understand pure healthcare and the settings of care that impact the patient engagement model.
Customer, right?
Right. They're the customer. They're shopping today. And you've got to understand how to sell to the health system that's ultimately got to sell the patient. So this waterfall effect of getting your product in front of a patient it's changing. And so the sell to model is not like it was in the past. Oh, this is what you've got. This is what we're going to use on you. And good luck to you. We hope it works. That's changing. You've got options now. And you've got options to take control of it. And these buzzwords that we're talking about today: protect, empower, and enable us to do more faster. But it can also empower, enable, harm faster if they're not managed and monitored in the right way.
This is exactly what I expected in the 45-minute conversation with you. It was fantastic. It's always great to work with you. I hope I could return a favor. So I'd like to thank our Health Stealth Radio audience for joining us today, and stay tuned for future episodes coming up in the next week. Mike, again, thanks so much.
Thank you very much, Frank. Glad to be here.
Thank you for joining us today in the shadows for this episode of Health Stealth Radio with Frank Cutitta. If you like the program, please be sure to share your comments on our social media sites, or feel free to contact us with suggestions for new and stealthy show themes. We look forward to welcoming you again for our next broadcast. In the meantime, stay safe out there.